So your presentation is called Managing Expectations with Gene Therapy. As said before, managing expectations is important. We have to know what we're looking forward to. So enlighten us.
Okay, thank you so much. So I'm the same guy, same accent, same origin, and many more disclosures in the field of gene therapy. I've got my fingers in many pies. Okay, I'm going to talk about things I know, right? It's easier. And I'm going to talk to you about two diseases that I know very well and that are very exemplative of what we can understand from gene therapy for our community. I say our community because now with Pila and Damien, I feel part of this community. Let's speak about Duchenne muscular dystrophy. And rather to show you data, I'm going to show you a patient. Can we try to get the two videos together? Any chance to get the two videos together, the technique? Do your best, guys. Yes, look at it. And now the other. So it's the same kid. On the right side, he has been treated, right? On the left side, it was before treatment. And look how faster he goes. He left behind because of the videos, but now is going much faster in the stairs. It's easier for him. Is it a miracle of gene therapy? Not at all. It's a miracle of steroids. We just give him steroids, right? So this kid has not received gene therapy. He has received steroids. By the way, you know that when we give gene therapy, we also give steroids. So the reason why I made the provocation to start with these videos is that before dreaming about gene therapy, before dreaming about all this innovative medication, we need to have a good standard of care. It doesn't make sense to start thinking about all these fancy approaches if we don't go for basic standard of care. So when it comes to Duchenne, there are plenty of things, but for CBNNT1, I mean, of course, we need to be sure that to take care of the contracture, to take care of the dystonia, to take care of the epilepsy, if any. So it's very important to maintain good standard of care if we want to make some benefit of the gene therapy. Then in Duchenne, we started to work on dogs. And that was in my previous life. We developed a gene therapy for dogs who could be treated by exon skipping and then by microdystrophin. And I must say these are dogs that are naturally sick, right? So we did not create sick dogs. We tried to treat dogs that are naturally sick. And rather than showing you a lot of data, well, this is actually the construct that we did with the AAV9, a full construct of a microdystrophin. And I'm going to show you what it shows in these dogs. Can I have the video, please? So it was a year with dogs with an I name, Izmir. So no, the video. No, the video. Yes, the video. Yes, you can. Fantastic. So as you see, this dog as a muscular dystrophy is weak, is not able to go above the bar and to get the food, even if he's committed, he does his best. That's our poor little Izmir. And then this is ici, which means here in France. And as you can see, this dog has the same disease, but he has been treated by gene therapy and he is definitely much more tonic and able to climb. Okay, so you can make maybe a double-blind randomized placebo study and try to figure out who is Izmir and who is ici. Obviously, it's quite clear that one dog has been treated and the other one has not been treated, right? So of course, as family, as a parent, when you see that, you say, I want my son to get a similar drug, to be like Izmir or like ici rather than the other dog, right? And these videos has been shown hundreds of times. And as you might imagine, it has fueled a lot of expectations in the field. And there are 4 drugs that have been, that went to the clinical trials from Geneton, Solid, Sarepta, and Pfizer. Well, yesterday, Pfizer announced that the phase 3 trial using this drug failed. Double-blind randomized placebo-controlled study with a drug very similar of the drug that was so helpful for dogs failed. Solid was on hold during a time because of safety issue, but one could move is Sarepta. And Sarepta made a construct with a different types of AAV, a different construct, and it was published in 4 kids were published in a very nice journal, which is called JAMA Neurology. Excellent paper that shows that indeed 4 kids who were treated get a much better muscle tissue. And they came with nice clinical data, and we can see that the improvement in this case was major. We talk about 9 points on a scale of 34. You don't need to be a neurologist to see that. You can ask to a blind medical student, he will see it. Very exciting. It works in the dogs. It works in humans, phase 1. Then they went to a phase 2 trial. And a phase 2 trial is already a placebo-controlled study. And unfortunately, we could not see a difference between the placebo group and the treated group because both groups were on steroids, like the boy I've shown you at first. And then they went to a phase 3 trial. And unfortunately, again, we could not see the difference between the treated and the untreated patients on the primary endpoint. So it brings me to the lesson number 1 that I've learned in Ljubljana streets. A man is not a dog, and even less a mouse. So it means that as a community, we can see amazing data in mice. We can see amazing data in dogs, but we are humans, and there is a big gap between dogs and humans. Of course, before going to human, we need to be sure that it works on dogs, that it works on mice, but it's not enough. And you may have very exciting findings in dogs or mice that are never translated into humans for one or another reason. So let's keep our feet on the ground. It is very important to have animal models, to have animal results. But it's not because something is amazing in animals that it will be translated in humans. Let's keep it in mind, okay? Of course, there are drugs that work. And now let me tell you a success story. And the success story is the story of spinal muscular atrophy. It's a similar story with the AAV9, the one that failed for Pfizer, and the full gene of SMN1. The first data were published in the New England Journal of Medicine. Spinal muscular atrophy type 1 is a terrible condition. The kids look normal at birth. They start having symptoms in the first weeks of life, and then they die within a couple of months, and they do not present any motor acquisition. Kids treated with this medication start doing much better. And rather than showing you a lot of data, as usual, I will show you videos. And I will talk about 2 kids. One who is born in a country where we have good waffles and good chocolates and good beers and good fries and good offensive football player. And the other one is born in another country. Let's call them Jack and John. They have the same disease. They have SMA type 1, and they have been treated with the same drug in my center in Belgium. So this is Jack. This John, sorry. So John is the French guy. French guy was diagnosed at the age of 2 months because he was floppy, and he was treated at the age of 4 months. And he survived. And not only he survived, but he is progressing. He's now able to eat the good French food. He became a painter. Look, he paints. And he's a sitting painter. He's a painter with a scoliosis, and he is a painter with a deficit of the upper limb, but he's a great painter. And nowadays, John goes to school, and he's a happy kid. He should be dead today, but he's a happy kid, smiling, happy to go to school, clever. He will never be ambulant, that's for sure, because we came too late. But Jack is born in southern Belgium. Can I have the video, please? And Jack, the difference of Jack, it's not beer, it's not chocolates, it's not waffles, is that in Belgium we have newborn screening. And so he was identified at birth and could be treated at birth. And Jack became a neurologist, and he is now able to take the reflex of his patients. Can I have the other videos of Jack on the right side, please, and the center of the. So he's not entirely normal, right? But he's doing so well in comparison. So a key message is, of course, the earlier we treat, of course, the better it is. It's not a matter of waffles. It's not a matter of chocolate. Also, I would like to. So there are ethical issues related to one-shot injection, because gene therapy is a one-shot injection. The first one is that parents and sometimes believe that one-shot injections means that it's a cure. It's two different concepts. You can have a one-shot injection and a treatment, not a cure, but a treatment, something that improves the child, that increases the quality of life, that allow our little John or Jack, I forgot because I mixed the name, of course, our little Frenchman to go to school, to be happy, to be alive, but not to be normal. It's a treatment, right? So it's not because it's a one shot that it's a cure. So we need to make the difference between both. And then it's very important to manage the expectations at the community level. And that's what I'm doing right now. In this fantastic paper published in this fantastic journal, which is the New England Journal of Medicine, there were two kids. And these two kids, look, they are there, they are doing incredibly well, but they were super young when they started the treatment. And may I have the video? And this is, we're going to see, this is one of these kids, of this super responder. He is doing amazingly well for a patient with SMA type 1. If I am the father of a patient with SMA type 1, I'll say, I want the drug of this kid. I want my kid to be like that. My kid is in the wheelchair. My kid is bedbound. My kid is a track. He has also SMA type 1. I want my kid to be like this. The problem is that this kid was so young at treatment. He was actually identified by screening, right? So it's unfair to make people believe that this is a treated SMA type 1. This was a patient identified by screening and treated at birth. It is a miracle. This kid is doing amazingly well. He should be dead today. It is a miracle, but it's not a SMA type 1 patient who has been treated. So my key message for you as a community was, first, a dog is not a human is not a dog, but also one patient is not another patient. Jack and John are different. This kid has been identified by screening. It means that something you see on the social network may not translate to your son, right? So let's keep very realistic about everything we see, everything we read. And we have exactly the same issue for Duchenne. We got a fantastic type phase 1 trial that did not translate into a larger trial. So then we need also to be aware of safety. Gene therapy is not, trivial in terms of safety issue, and you may see sudden, unexpected, serious adverse reaction. This is a second lesson I've learned in the street of Ljubljana. Well, safety events are not the one that you generally think about. I don't think that this is a patient of Dr. Osred Kar, who has received Maging Damien's herbs. But just joke aside to say that in the SMA clinical trials, we could see some events that can be quite concerning, like thrombomicroangiopathy. It's very rare, but we need to be aware of that, and we need to have a good safety plan because, and this is a third lesson of Ljubljana Street, it's good to hope to be lucky, but it's even better to have a proper risk management plan in place. So it's good to ask the dragon to give us the luck, but it's maybe not enough. We also need to think and to properly prepare our trials by getting the right tox safety and then to have a right design of our trials to be sure that collectively we are ready to manage any safety event that may happen during a trial. So then comes the problem of the risk perception. This is me with one of my patients. Let's imagine that I've got a drug that is very efficient, that could help him to walk, but that can cause 10% of problem. My patients could think, with this drug, I have 90% of chance to go better. And I would say, well, if I treat 100 of my patients, I could kill 10 of them. So the perception of risk is very different between doctors and patients. When you think about risk, you think about one patient, your son, your daughter. When we think about risk, we think about all of you, right? So sometimes we have a different way of understanding what means a risk. And so my two last slides, I've left Ljubljana to go back to Denver. Gene therapy presents foreseeable and unforeseeable challenges, but it can operate miracles. And let's remind the smile of this kid, and let's make the miracles happen all together. And all together we'll do it as a team. So here's my team in Oxford, but I feel really now part of a team, and that's together that we can operate miracles. Thank you so much for your attention.